Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Theresa Lowry Lehnen. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of migraine. Migraine, characterized by recurrent episodes of moderate to severe headache, is the most common neurological condition affecting approximately 12 to 15% of individuals worldwide. It is a complex, multifactorial disorder with a strong genetic basis and high disability rates, which involves a series of abnormal neuronal networks interacting at different levels of the central and peripheral nervous system. Migraine involves multiple cortical, subcortical, and brainstem regions which account for the pain and the wide constellation of symptoms characterizing the condition. Migraine headache generally shows a multifactorial inheritance pattern, but the specific nature of the genetic influence is not yet completely understood. Approximately 70% of patients have a first-degree relative with a history of migraine, and the risk is increased fourfold in relatives of people who have migraine with aura. Migraine is a significant cause of disability worldwide. It is 3 times more common in women than men and is classified by the World Health Organization as the 7th most disabling disease worldwide and the 4th most disabling in women. The lifetime prevalence is 42% in females. The World Health Organization Global Burden of Disease Studies ranked migraine as the second highest cause worldwide of years lost due to disability. An estimated 1 billion people experience migraine globally, and there are between 600,000 and 700,000 people with the condition in Ireland. It is estimated that 13,000 people in Ireland experience a migraine attack daily, the majority of whom are part of the workforce. Migraine is estimated to cost the Irish economy €250 million a year. Migraine manifests as recurrent attacks of throbbing, pulsatile, unilateral, often severe headache that intensifies with movement or physical activity, with associated features such as nausea, vomiting, difficulty speaking, numbness or tingling, sensitivity to sound, and photophobia. Common migraine triggers include hormonal changes resulting from menstruation, ovulation, oral contraceptives, or hormone replacement. Other common migraine triggers include head trauma, lack of exercise, sleep changes, stress, strong odors and environmental factors, caffeine, alcohol, and certain medications such as nitroglycerin, histamine, reserpine, hydralazine, ranitidine, and estrogen. The identification of migraine trigger factors is an important part of the clinical history and headache consultation. In some cases, migraine headache begins with no warning signs and ends with sleep. In other cases, the headache may be preceded by a prodromal phase that includes fatigue, euphoria, depression, irritability, food cravings, constipation, neck stiffness, increased yawning, and/or abnormal sensitivity to light, sound, and smell, and an aura phase that includes a variety of focal, cortically mediated neurological symptoms that appear just before or during the headache phase. Symptoms of migraine aura develop gradually, feature excitatory and inhibitory phases, and resolve completely. Positive and negative symptoms may present as scintillating lights and scotomas when the visual cortex is affected, paresthesia and numbness of the face and hands when the sensory motor cortex is affected, tremor and unilateral muscle weakness when the motor cortex or basal ganglia is affected, and aphasia when the speech area is affected. The pursuant headache is commonly unilateral, pulsating, aggravated by routine physical activity, and can last from a few hours to a few days. Migraine is more than just a headache. It is a complex neurological disorder that affects multiple cortical, subcortical, and brainstem areas that regulate autonomic, affective, cognitive, and sensory functions. Prodromes are symptoms that precede the headache by several hours. About 60% of people who experience migraines report premonitory symptoms that occur hours to days before the headache onset. Although prodromal features vary, they tend to be consistent for a given individual. Symptoms that are most commonly described with migraine in the prodromal phase of an attack point to the potential involvement of the hypothalamus with symptoms such as fatigue, depression, irritability, food cravings, and yawning, and the involvement of the brainstem with symptoms of muscle tenderness and neck stiffness, the involvement of the cortex with symptoms of abnormal sensitivity to light, sound, and smell, and of the limbic system with symptoms of depression and anhedonia. A diagnosis of migraine is based on clinical history, symptoms, detailed history of the characteristics of the headache, a thorough neurological exam, and outruling other causes. The history should include documentation of all the medications the patient is taking, the timing of acute medications, and whether or not it is beneficial. Imaging scans such as a CT scan or MRI can rule out other causes, including tumours, abnormal brain structures, and stroke. Migraines are classified as migraine without aura, probable migraine without aura, migraine with aura, probable migraine with aura, chronic migraine associated with analgesic overuse, childhood periodic syndromes that may not be precursors to or associated with migraine, complications of migraine, or migrainous disorders not fulfilling other criteria. The most recent recommendations are contained in the International Classification of Headache Disorders, the ICHD-3. These recommendations have been incorporated into the World Health Organization's International Classification of Diseases, the ICD-111. In addition to the main classification of migraine, the ICHD-3 includes an appendix containing a number of additional migraine subtypes and associated variants, many of which are well known but which are not included in the formal classification of migraines. The infographic on the left shows the ICHD-3 2018 classification of migraine, and it shows the types of migraine, which is migraine without aura, migraine with aura and its subtypes, chronic migraine, complications of migraine and its subtypes, probable migraine, and episodic syndromes that may be associated with migraine. The infographic on the right shows the ICHD-3 2018 migraine subtypes and variants from the appendix, and this includes migraine without aura and its subtypes, chronic migraine and the subtypes listed underneath, complications of migraine, episodic syndromes that may be associated with migraine, which include infantile colic, alternating hemiplegia of childhood, and vestibular migraine. Migraine without aura is the most common migraine and has specific diagnostic criteria. International Headache Society diagnostic criteria state that the person must have had at least 5 headache attacks that lasted 4 to 72 hours untreated or unsuccessfully treated, and that the headache must have had at least 2 of the following characteristics. unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by or causing avoidance of routine physical activity. In addition, during the headache, the patient must have had at least one of the following: nausea and/or vomiting, photophobia, and phonophobia. These features must not have been attributed to by another disorder. Migraine with aura occurs in approximately 20 to 30% of patients. The migraine aura is a complex of neurologic symptoms that may precede or accompany the headache phase or may occur in isolation. It usually develops over 5 to 20 minutes and lasts less than an hour. In migraine with aura, the aura occurs after the prodrome stage. The aura can be visual, sensory, or motor, or any combination of these. Auras most commonly consist of visual symptoms, which may be negative or positive. Negative symptoms include negative scotoma or negative visual phenomena such as homonymous, hemianopic, or quadrantic field defects, central scotomas, tunnel vision, altitude visual defects, and complete blindness. Sensory symptoms, including paresthesia, occurring in 40% of cases, constitute the next most common aura. They are often chereo-oral, with numbness starting in the hand, radiating to the arm, and then spreading to the face, lips, and tongue. As with visual auras, positive symptoms are typically followed by negative symptoms, and paresthesia may be followed by numbness. Sensory aura rarely occurs in isolation and usually follows a visual aura. The rate of spread of sensory aura helps distinguish it from transient ischemic attack or a sensory seizure. Just as a visual aura spreads across the visual field slowly, paresthesia may take 10 to 20 minutes to spread, which is slower than the spread of the sensory symptoms of a TIA. Motor symptoms occur in up to 18% of patients and are usually associated with sensory symptoms. Motor symptoms often occur as a sense of heaviness of the limbs before a headache, but without any true weakness. Speech and language disturbances have been reported in up to 20% of patients. These disturbances are commonly associated with upper extremity heaviness or weakness. The next phase is known as the attack phase. This is the most acute or severe of the phases when the actual migraine pain occurs. In some people, this can overlap or occur during an aura. Attack phase symptoms can last anywhere from hours to days. Symptoms of a migraine can vary from person to person and may include increased sensitivity to light and sound, nausea, vomiting, dizziness or feeling faint, and pulsing and throbbing pain on one side of the head, either on the left, right, front, back, or temples. In 60 to 70% of migraine attacks, the headache is unilateral, but it can also be bilateral. The pain can move around the head and face during or between attacks. Neuropathic facial pain is very common in migraine patients and is often misdiagnosed as sinus pain, dental issues, trigeminal neuralgia, or temporomandibular joint problems. After the attack phase, a person will often experience the post-drome phase, usually associated with change in mood and feelings. These can range from feeling euphoric and extremely happy to feeling very fatigued and apathetic. A mild, dull headache may persist. The length and intensity of these phases can occur to different degrees in different people. Sometimes a phase is skipped and it is possible that a migraine attack occurs without causing a headache. Postdromal symptoms may persist for 24 hours after the headache and can include a washed out or irritable feeling, euphoria, muscle weakness, myalgia, and anorexia or food cravings. Experts generally refer to low, moderate, and high frequency episodic migraine. Low being 1 to 4 days per month, moderate 5 to 9 days per month, and high 10 to 14 days per month. Migraine is defined as episodic if it occurs less than 15 days per month. Patients should be advised to keep a detailed diary, including details about the severity of the headaches, associated features, acute treatments used, effects on lifestyle, and possible triggers. This provides useful clinical information and can help confirm the diagnosis. Treatment of acute migraine include analgesia, non-steroidal anti-inflammatories, and triptans, which should be used no more than 4 to 6 days per month in order to avoid medication overuse. Individual patients may respond effectively to simple analgesia combinations such as paracetamol and ibuprofen taken together. Alternatively, some patients may need a combination of medications from all three categories, for example, paracetamol, naproxen, and frovatriptan. These medications can all be taken at the same time. If the initial combination of acute medication does not work, it is important to change the medication combinations. The current recommendations for treating acute migraine attacks are to consider a combination of paracetamol, nonsteroidal anti-inflammatory, and triptan. Triptans are recommended early in the attack and should be taken when the headache is just beginning to develop and preferably before the headache is established. Studies have shown that triptans do not work as well if taken too early. If migraine recurs in patients who respond, repeat the dose at a minimum of 2-hour interval, being careful not to exceed the maximum dose and frequency. Many patients report that triptan are the single most useful drug for the treatment of acute attacks. Triptans are a class of medications that are used to ease the symptoms of a migraine attack or cluster headache. Triptans are not painkillers. They work by imitating the action of a brain chemical called 5-hydroxytryptamine, also known as serotonin. They are also known as 5-HT1 agonists and include almotriptan, electrotriptan, frovotriptan, naratriptan, rizatriptan, sumatriptan, zolmitriptan, and come in a variety of different brand names. Sumatriptan is currently the most versatile of the triptans with an oral, nasal, and subcutaneous formulation. Triptans are licensed for people aged between 18 and 65 years of age, both for migraines with and without auras. They are not suitable during pregnancy and are also not suitable for people with a history of hypertension or CVD. This infographic shows the different treatments of acute migraine. It includes paracetamol 500 milligrams, 2 tablets every 6 hours, not exceeding the maximum dose. The NSAIDs include naproxen or ibuprofen, diclofenac, aspirin, or mefenamic acid. The triptans include medications such as sumatriptan, zolmitriptan, frovatriptan, almotriptan, electriptan, and naratriptan. Chronic migraine is distinguished from episodic migraine by its clinical, epidemiological, socio-demographic, and comorbidity profiles. Chronic migraine is associated with high disability and has a significant impact on quality of life and behavior. chronic migraine has specific diagnostic criteria. Chronic migraine is characterized by the experience of migrainous headaches on at least 15 days per month. Patients with chronic migraine presenting to primary care are often referred for management to secondary care and make up a large proportion of patients in specialist headache clinics. Many patients with chronic migraine also have medication overuse, defined as using a compound analgesic, opioid, triptide, or ergoid derivative on at least 10 days per month. Classes of medications that are effective for migraine prevention include antiepileptics, antidepressants, antihypertensives, botulinum toxin, and calcitonin gene-related peptide inhibitors known as CGRPs. Antiepileptic, antidepressant, and antihypertensive medication may be considered initially because they are more affordable. Antiepileptic medications are generally well tolerated. The main adverse effects of topiramate are weight loss and dysarthria. Sodium valproate is useful as a first-line agent. It can help to stabilize mood and can benefit patients with concomitant mood swings. However, it can cause weight gain, hair loss, and polycystic ovary disease, and also carries substantial risks in pregnancy, so is not recommended for younger female patients. Tricyclic antidepressants are good second-line alternatives. Although selective serotonin reuptake inhibitors are widely used, data regarding their efficiency in migraine prevention are lacking, and SSRIs are consequently not recommended for migraine prevention. Antihypertensive medications such as beta blockers should be tailored to the individual and may not be the ideal for elderly patients or people with depression, thyroid problems, or diabetes. Calcium channel blockers are another possible choice of treatment. Botulinum neurotoxin, better known as Botox or botulinum toxin A, may be beneficial in patients with intractable chronic migraine that has failed to respond to at least 3 conventional preventative medications. Botox can reduce the frequency and severity of migraines after 2 to 3 months. Botox injections are expensive and must be administered every 8 to 12 weeks in order to be effective. In Ireland, access is very limited via the public healthcare system, and private health insurers do not usually reimburse patients for Botox injections. It is also recommended that 3 GON block injections are used in advance of a patient being listed for Botox. Prophylactic oral therapies are indicated for the treatment of migraine when symptoms occur on at least 8 to 10 days per month and are of moderate to severe intensity. Preventative drugs should give at least 30 to 50% improvement in headache disability overall without having significant side effects. Preventative agents should start at a low dose, be increased in small increments every 2 to 8 weeks, be given an adequate trial for 2 to 3 months at the maximum tolerated dose, avoid overuse of analgesia, consider comorbid medical conditions, aim to use a single medication that may treat multiple disorders if possible, and re-evaluate therapy at a reasonable interval of 3 to 6 months. Contraception should be discussed with women of childbearing age and the potential risk of the preventative medications, primarily during pregnancy and breastfeeding. The progesterone-only pill, the progesterone injection, and progesterone implant can be prescribed for women, even in the presence of migraine with aura. First-line prophylactic therapies for migraine include topiramate 25 to 400 milligrams daily, amitriptyline 2.5 to 150 milligrams daily, propranolol 20 to 160 milligrams daily, and candesartan 4 to 32 milligrams daily. Second-line prophylactic therapies for migraine include sodium valproate 200 to 2000 milligrams daily, pizotyphon 3 to 4.5 milligrams daily, metoprolol 50 to 100 milligrams daily, venlafaxine 37.5 to 225 milligrams daily, and gabapentin 900 to 3000 milligrams daily. Second-line therapies also include physiotherapy, acupuncture, and in the case of menstrual-related migraine, a long-acting triptan 2 days before the period commences to the third day of the period. Conservative management strategies should be encouraged and include a healthy lifestyle, daily exercise, a balanced diet, good hydration, and good sleep hygiene. The avoidance of stress, alcohol, smoking, and other stimulants should be encouraged. Acupuncture over 5 to 8 weeks combined with symptomatic treatments can help reduce the frequency of migraine attacks, and physiotherapy may also be effective for those with migraine associated with neck pain. For patients with regular, rapid, and persistent vomiting, non-oral routes of administration of acute medications, for example rectal diclofenac and paracetamol, and nasal or subcutaneous sumatriptan should be considered. Sometimes intravenous fluids, intravenous paracetamol, intravenous or intramuscular antiemetics, and/or intravenous or intramuscular injections of nonsteroidal anti-inflammatories are also required. Morphine and opiate-based preparations should be avoided due to the risk of medication overuse, dependency, associated comorbidities, and side effects. The regular use of steroids should also be avoided. Greater occipital nerve blocks can be used as an acute treatment in migraine by injecting a mixture of depomedrone and local anesthetic lidocaine. This can be carried out in general practice, but usually takes place in A&E departments. GON provides short-term relief of up to 2 to 3 months. Side effects are rare, accounting for less than 1%, but can include lipoatrophy at the injection site with loss of hair growth. Neuromodulation is a novel treatment approach for patients with episodic and chronic migraine. There are several different devices available, and the evidence for their use is variable. The most simple and non-invasive are handheld devices used by the patients every day for short periods of time, usually less than an hour each day. Alternative migraine therapies include biofeedback, mindfulness, reflexology, and the use of TENS machines. The Headache Impact Test is a patient questionnaire which can be used at the 3 to 6 monthly review and a resource that helps the patient describe the way they feel and explain what they cannot do because of the headache. The most promising new preventative treatment for migraine are the calcitonin gene-related peptide monoclonal antibodies, known as CGRP. These new anti-CGRP treatments are mainly for prophylaxis and are delivered by intramuscular or intravenous injection once every 4 to 12 weeks. Cost and access to these new treatments are a significant barrier in Ireland. Erenumab, known as Aimovig, was available on a managed access program but closed to new patients in June of 2019. NCPE issued a recommendation regarding the cost effectiveness of erenumab for the prophylaxis of chronic migraine and episodic migraine in adults who have at least 4 migraines per month where 2 or more prophylactic treatments have been unsuccessful. NCPE also recommends that erenumab for the treatment of chronic migraine be considered for reimbursement if cost effectiveness can be improved relevant to existing treatments. The HSE is formally considering the NCEP recommendations. Cost effectiveness of erenumab for episodic migraine is more uncertain, and the NCPE recommends that reimbursement not be considered at this time. Migraine is 3 times more common in women than in men in the 15 to 49-year-old age group, and menstrual migraine affects 60% of these women. Menstrual migraine can occur before, during, or immediately after a period or during ovulation. Women are more vulnerable to headache when the levels of estrogen and progesterone change. Because oral contraceptives influence estrogen level, women on birth control pills may experience more frequent menstrual migraine. In many women, migraine around the time of menstruation is more difficult to treat. The attacks are usually of longer duration and are more severe than migraine at any other time in the cycle. In general, treatment is the same for menstrual migraine as non-menstrual migraine. If migraine is infrequent, NSAIDs alone or with paracetamol or in combination with a triptan may be helpful. NSAIDs are also beneficial for treating menstrual cramps. If migraine is frequent, predictable, prolonged or poorly responsive to therapy, consideration should be given to mini prophylactic treatment. Other prophylactic options for menstrual migraine for those with PMM and MRM is an approach to suppress ovulation using the progesterone-only pill or the progesterone injection Depo-Provera, which is given 12 weekly, or progesterone implant known as Implanon, or the Mirena coil, although the Mirena usually does not suppress ovulation, so it may not prevent PMM or MRM for some women. A further approach is to supplement estrogen during the days when estrogen levels drop significantly with an estrogen-containing gel. Irrespective of the frequency and severity of attacks, for those affected, migraines can be sufficient to impede daily living activities, and for many it can have a seriously debilitating impact on their well-being and quality of life. Migraine is mainly managed in primary care and is the most common headache disorder seen in general practice on a day-to-day basis. The Sláintecare towards Self-Care and Headache pilot programme was set up in 2020 to provide a multidisciplinary team of healthcare professionals and an agreed care pathway to provide migrainaires with a holistic and more successful strategy for coping with migraine. The programme has 3 components: the implementation of nurse-led clinics, collaboration with selected community pharmacies, and self-management training sessions and peer support groups in partnership with MAI. To improve diagnosis, referral and support in primary care settings, the programme set up community-based sessions for general practitioners in pilot clinics and educational sessions for pharmacists by the MAI, IPU and NCP Neurology. Approximately 952,373 people in Ireland are living with headache disorders, and 2.5 million days are lost from work or school due to migraine each year. Headache represents the second most frequent condition presenting to AMAUs and the seventh most frequent to acute medical units. Approximately 7,000 people with headache disorders are on waiting lists in Ireland, and each consultation can trigger a further 2 to 3 visits to hospital. The Headway Pathway programme has the potential to shift care from the acute to the community sector and offer holistic patient-centred care. Significant advances have been made in migraine treatments, research and developments over recent years. Patient education, compliance, and therapeutic regimes and lifestyle changes are key to successful long-term management. Ongoing research, and a future that is likely to deliver more novel, acute, and preventative migraine treatments that are effective and well tolerated, offers additional hope for those seeking effective and reliable relief from the disabling effects and burden of migraine. So let's now consider the role of the general practice nurse. General practice nurses are involved in screening, assessment, treatment, and management of migraine. We offer a holistic, person centered approach. We provide ongoing support and education to our patients who have migraine. We establish a therapeutic relationship with our patients, assess their understanding of the migraine condition, establish goals and expectations for successful management of their condition, and evaluate the physical, emotional, and psychological effects of migraine on their well-being. General practice nurses are communicators, we are advocates, and we provide counselling. We provide assessment, monitoring, audit, and evaluation of the therapeutic regime on a patient, and this is a continuous process. Many nurses can now prescribe medications, perform diagnostic examinations, and prescribe other types of medical treatments, either independently or in conjunction with a doctor. We are leading the way in quality improvement initiatives and research, and we implement person-centered care, monitoring and evaluation of symptoms, outcomes, and patients' responses to therapy. So this is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on migraine, which is part of an online education series for general practice nurses produced by the Irish Practice Nurses Association. My name is Theresa Lowry Lehnen. I'm a member of the Carlow branch of the IPNA. Thank you.